You are now listening to Protecting Your Nest with board-certified family medicine and obesity medicine specialist Dr. Tony Hampton. For more, visit drtonyhampton.com. Welcome to the Protecting Your Nest podcast. There are many challenges we all face as we work to achieve our health-related goals. For some of us, it's just having the right knowledge, and for some, it's having a little coaching to help us along our way. But just for a moment, I want you to imagine what life would be like if your ancestors' history was the same as our indigenous American brothers and sisters. Imagine just for a moment having the memory of being sent to a boarding school, and in this example, the Carlisle Indian Industrial Schools to be specific, not to ensure that you get the best education, but to ensure you are trained in the ways of Western culture, with the ultimate goal of stripping you of your traditional clothing, your language, your name, and even something as basic as your hairstyle. Now imagine spending time in those industrial schools, and by the time you were able to go back home to visit your family on your family's reservation, you've lost the ability to communicate with the very family that helped raise you. What emotions would you feel? Now imagine being an indigenous American parent who has to live with fear that someday one of your precious babies or even young child could be forcibly taken from you to be adopted, even though you are capable and able of raising your child yourself. Back then, it was about absorbing and assimilating into the ways of Western American society. This is the history of America. It is also the present as well. In fact, the Indian Child Welfare Act that was enacted in 1978 in response to the unfair treatment of indigenous children is still active. This was done only after studies were done to reveal the truth that as many as 25 to 35% of indigenous children were being separated from their parents, extended families, and communities by state child welfare and private adoption agencies. And like the examples I shared in my podcast about COVID-19 and systemic racism, it's just another example of why our E in the ROPE acronym is so important. The experiences of our ancestors and our own shape our emotions in every single decision we make. Today, we will meet a clinician whose life work is to help not only indigenous Americans, but also the many Latin American patients she sees in New Mexico. I hope her unique perspective will help us all put our own journey into perspective, while also strengthening, our level of concern for our brothers and sisters from other cultures. Today's guest is Jamie Sandoval. Jamie is a nurse practitioner specialist in New Mexico. She's been a nurse since 2005 and worked in critical care for 7 years, mostly as an open heart recovery nurse. She obtained a Bachelor of Nursing, and that was attained from Eastern New Mexico University. And she also graduated from Walden University to acquire her Family Practice Nurse Practitioner training in 2018. She's currently working for Presbyterian Medical Group Family Practice and is the medical director of Round 2 IV Infusion Clinic in Albuquerque, New Mexico. She has been married for 11 years and has 3 beautiful girls, and has been teaching the ways of keto for about 3.5 years. So I am so pleased to welcome you, Jamie, to Protecting Your Nest, and I really want to thank you for being here today.
Hi, Tony. I'm so appreciate you having me today. I look forward to our conversation that entails on our culture here in New Mexico, so thank you.
Absolutely. I was very thrilled when your name popped on my radar, and really haven't had a lot of experience with the culture that you're serving. So I'm really excited about that. I did go to Xavier University in New Orleans, and when I attended this school, I was immediately struck by the culture that seemed so different from the culture I was accustomed to in Chicago. I've really never been to New Mexico where you practice, but I am assuming that there's a unique culture there as well. You've been in New Mexico your whole life, so tell me why you decided to stay planted in New Mexico and start your family and career there.
New Mexico is very unique. Yes, we do have many cultures here. We have our indigenous Native Americans. We have our Hispanic Latin culture. We have just an all-around majority of different, almost like a melting pot here in New Mexico. It's very amazing. I love it. Not only that, our beautiful landscape here too kind of drew me into not really wanting to go outside the state. We have the Rocky Mountains, we have the desert, we have white sands, we have 4 seasons. And the weather's warm, but it's not too hot like Phoenix. There's a lot of, questionable things of why should we stay here in New Mexico versus going somewhere else. And I'm really glad that I stayed here in the community to help with practicing medicine, with my career in nursing and practicing medicine, because we are in such need of providers here in New Mexico. It's very limited. And I really enjoy it. Yeah. We've planted here in New Mexico. I've been lived here for 40 some years, as old as I am. And it continues to amaze me when we go to different parts. So, yes.
I'm always jealous of beautiful landscapes when you live in a flat place like Illinois, so I'm always jealous. So I know it's beautiful there. Every time I visit a place with a lot of mountains, hills, valleys, and things of that nature, I'm always amazed at the greatness of the world. So that's definitely a great reason. And I definitely understand, even in Illinois, our rural communities, they struggle to find clinicians that want to live in those communities. So I think I could understand why you'd want to stay and serve a community that you grew up in and you understood that there was a need. So that's really cool. So thanks for sharing that. I also want to ask you, how you ended up in this low carb and keto space. Many of us have our own stories to tell. And I was wondering if you had a personal story that led you there from your own health, or was it just something you discovered as you tried to help your patients?
Yeah, that's a great question. It's like, how do we all get here, right? How do we start? How do we adapt in or changed our practice thoughts? How do we start our own lifestyle changes? Well, unfortunately, through my 30s, after my 3rd child, I became sick and began to have migraines, and then thyroid problems and depression, anxiety issues, and severe chronic pain where I couldn't hardly do my 12-hour shift because I'd want to vomit from the pain by the end of the day. I had diagnoses of prediabetes, hyperlipidemia, fibromyalgia. I had irritable bowel. They continually had abdominal issues. Had gallbladder issues where at one point, in the end, they wanted to just go ahead and take my gallbladder out. So I guess I'd stop complaining, right? So the last diagnosis was the possibility of MS. And I just had it. No matter how much I worked out, no matter what I ate, just every day was miserable. So luckily my husband just picked up a cookbook and he said, let's just try this one. I tried everything. I tried every diet out there, Jenny Craig, Weight Watchers, you name it, 6 meals a day, tried it all. And nothing worked. We started with this simple keto, low carb for thyroid type cookbook, and I began reading it, doing the recipes of which was provided and kind of getting an idea. Within a month's time, my husband's like that I had such an uplifting mood change that he was like, we're never getting off this diet. So all of a sudden I realized, I'm actually more positive. I'm not so down, and my pain's feeling better. I began coming off medication within about 2 months of a large amount of medication that I was on from different specialists, from cardiology to infectious disease to you name it. I was seeing somebody. So 6 months down the line of trying to do this on my own, I ended up finding all of you and many other off of dietdoctor.com, Ken Berry. I started getting help and understanding and the common sense behind it. And it just clicked. So I began educating myself more and more, to the point where I even switched my children to low carb. And they don't eat so much ketogenic, but they do eat low carb. And their life started changing. They began to not have rashes anymore. Eczema started going away. Abnormal cellulitis my daughter used to get. Massive tummy problems that both of them had, They weren't sleeping correctly. My depression with my middle child, well, they got better. And my middle child, who was 16 then, got off antidepressants within a month. So my whole family just adapted this lifestyle. No one's perfect at it. I don't expect anyone to be perfect at it. Everyone and me and my family always have our hiccups. Yes, we do. But we always, for the most part, live a low carb, keto, carnivore-ish type lifestyle. So it has significantly helped me in my health, in my well-being, in my family's well-being, that I started looking at my patients. And granted, I'm new to being a provider. I'm not saying that I'm this long-term provider that's been doing family practice for years on end. But I just started noticing that not every, but 80 to 90% of my patients all have the same diagnosis that I did.
Mm-hmm.
And when I found lowcarbusa.org, all these, wonderful people, and they helped me start, with my own, I guess, understanding the whole thing and why we are so sick, I began incorporating and teaching people in my practice, because I would give them options. I would say, you have a choice.
Mm-hmm.
And it's very hard, like we were talking about the indigenous, Native Americans that we state here, or our Hispanic culture, Latin culture. Mm-hmm. How was I going to bring that to the table? And that's where I've kind of continued on, and just, it really is helping. So I love it. I really do.
I love everything. I thank your husband for his curiosity. I've had so many guests talk about migraines going away. Monique Travis, previous guest, Dr. Kristen Bear,
yes,
talk about migraines go away. She's awesome.
Yeah, I have not had a migraine since I started this.
That's insane. And Dr. Kim Berry talked about how he's a nicer guy to be around. He's already a tough guy, but he's nicer. He's warm and fuzzier now, because I hope he hears this, because he's just kind of mellowed out. And for your husband to honestly declare, this is the woman I wanted to marry. This is the relationship I wanted to have, and I want to retain that. These are the things that you weren't even seeking when you started your journey. You probably were more concerned about fibromyalgia and pain and those things, and yet the relationship got better. I had problems with irritable bowel, and this approach has helped me. I just don't have problems with irritable bowel. It's a different, unless I push the envelope and eat what I shouldn't eat for more than a few days. So I really appreciate you sharing your story. And I'm so thankful that you have benefited like that, because without you benefiting, you can't help all the people that we are talking about today. So, I started my comments reflecting on historical factors that could affect indigenous patients from, trusting. I mean, how can you trust having that type of history in this country? Mm-hmm. And then I look at your profile on LinkedIn, and I see what appears to be a white blonde woman, and my brain says to me, how in the heck, are you going to be able to get trust from folk and coach these patients when they may look at you as, a person that represents the problem that has led to some of the struggles they've had. So how were you able, first of all, what does your culture represent? Who are you from a cultural perspective? And then how were you able to acquire trust in this community that you're serving?
Yes, that's a very, very good point. I do. You always hear that they get white coat syndrome when they come in and their blood pressures go up and they're just nervous. But once they get to talking to me and understanding who I am and where I came from, they become much more relaxed and open up and just love me for understanding everything. So just going back to my culture and that I do look white and blonde, and not that my hair is naturally blonde, just my culture or my ethnicity. My grandfather grew up on the Taos Pueblo. He was one that was suppressed and not speaking Spanish or native or couldn't speak it. So he never taught it to my parents, my uncles and my dad. But he was also Hispanic, Spaniard descent as well. So my father is a large majority of Native and Hispanic, like a lot of our community here. But on the other side, where my mom, where I have the lighter skin, genes were just stronger, she is a descendant from English, Scottish, German, and some French and Irish. Is her mom's French and Irish. So I am very, very mixed. And I grew up in northern New Mexico, which is so different from southern New Mexico, from central New Mexico. So I grew up in a small town, so I can reach people in that understanding as well. I can switch into a sense of speaking with my accent so they feel more comfortable. Mm-hmm. And they love it. They love it. They feel connected because I am from here, even though I don't look like it. I do get all the time, oh, your last name's Sandoval. You're married because I look white, and it offends me. And I'm like, no, my last name actually is Montoya, And so it's very, in a sense, at first, like you said, I get that. I get that pushback until they understand where I come from. And I always give them a little intro of where I am, especially for new patients, where I came from, what I do. And they really do appreciate it to be able to sit there and then open their minds and listen to me. I think it makes it a lot more comfortable at knowing I understand the culture here. I understand the way of living. And again, they appreciate it. So that helps.
Yeah. And it makes sense. I know that even when we try to teach with our healthy living program, which is not really happening now because of the pandemic, that'll kick back in hopefully soon. But when we get in front of people, we sometimes are very conscious of who we ask to speak, because we do want to make sure the message resonates with people and they trust the messenger. Mm-hmm. But it sounds like you have, like I said, the outward appearance doesn't tell the whole story. So, but I think it's important, and it's okay. Like, it's okay that we have to do these things, because when you understand the history, it should be easier to understand why it's necessary to do that, no matter what the culture is. You want to, you got to build trust. And Exactly. If you build trust, then you have the capacity to connect, because ultimately you just want to, if you have a message that you think is important to share, you want to make sure it reaches as many people as possible, which is why we're having our conversation during a podcast. We want to share the message that there's another way. So, and I do that. My population is a little, different. It's mostly African American, and I'm asking my patients to do things that are a struggle, and some of them really look at me twice. And, when I say, okay, let's cut back on the cornbread and the mac and cheese that's made from pasta, and the battered meats, and the starchy sides, the potato salads, the dressings, and things of that nature. And it's a struggle. So when it comes to the indigenous Americans you serve and the Latin Americans you serve, are there specific examples of foods that when you ask them to cut back on it, they look at you with, crossed eyes, and you find, what's been some challenging foods, and things that I wouldn't even know about, I'm sure, but give me some examples.
Well, New Mexico is famous for the red and green chili. Of course, we grow green chili in a large majority of our state, which, for red chili as well. But a lot of New Mexican, we all, whether we're native or New Mexico, we all love chili. We all love chili. We love red and green. It's a huge part of almost many New Mexicans every meal, but it's not.
Really?
Red and green chili is not bad for us. It really is not.
Right.
Depending on how you make it. Some people, every corner, like I said, from north to central to south, make their chili different. They're taught different. It's almost different, but the same. So some people make it with flour, some make it with cornstarch, some don't make it with any carb-related product at all. A lot of people hear every meal, it ends up being, most times I hear, oh no, I can't live without my tortillas. I can't live without my potatoes and beans and rice. That is like every meal with 2 or 3 of those, and then maybe a protein and a vegetable. So 1, those are cheap. And 2, we grew up eating them. Pinto beans, enchiladas, tamales, sopapillas, native tacos, Indian tacos, which are amazing with the fried bread. Our breads, it's very carb oriented. It really has. I mean, I would eat potatoes 3 times a day and tortillas all day long. And how do we break that cycle of that they don't realize that they're actually putting sugar in their mouth, right? So that's kind of where it comes down to, or how do we teach them how can we make these in a healthier manner and still enjoy our tacos, our tamales, everything that we eat.
And I think that's the secret sauce, like, the food replacements, right? So I'm sure you have tons of traditional foods that you do want to retain those traditions because we know the history and we think it's important that we keep our culture. So, I personally, want to do some of that work, even with the diet doctor. So they blessed me with a web page called the LowCarb Corner. So for those who are listening, check out just search LowCarb Corner in my name, and you'll see some columns every month, and those things. The goal is to start to, maybe share some recipes. I'm going to start doing that very soon, and I really appreciate anybody out there who's able to help us, the cooks, whoever, who are creatively thinking of ways to keep that ethnicity, keep the ethnically appropriate food in front of our patients so that they will have some keto-friendly replacement options. So of the things that you spoke of, are they embracing any alternatives that are similar, like how they make tortilla, and things like that? Have they embraced those alternatives as ways to make their food as well?
Yes. They really, and I'm very thankful my patients really take a step back and give it a try. Let's take your tortillas, for instance. There's not a homemade recipe that has been comparable to our original tortilla recipes here. But there is on the market now, which I am thankful for, like Santa Fe Tortilla Company out here in New Mexico has made a very low carb, very similar to our traditional, but it's only 4 net carbs. So I try to get my patients to switch to that. I mean, and they taste it. I know Mission has one, but like I'm telling you, Santa Fe Tortilla Company, if you guys can ever try those, 4 net carbs, amazing. Like they taste good. So I use that for a lot of recipes. I even use it for cutting it into 4s, layering it with your red chili, cheese, enchilada, making a little enchilada single, which is a lot less carbs. You're looking at only 3, depending on how many layers you do, 3 or 4 net carbs for the whole enchilada compared to normal, which would be probably 28 or so, or more, depending on your serving size, right? I try to get patients to switch to cauliflower rice and give it a try, and informing them how the difference between cauliflower rice versus putting a serving size of rice is like putting 10 teaspoons in their mouth, and they just trying
Mm-hmm.
to get them to start understanding these common grounds of food that we eat in both Native and Hispanic culture here, that we can try and change it up. But also these, how much sugar you're actually putting in your mouth with that potato, how much are you putting in your mouth with that rice that you're eating? So trying to look at alternatives for that. The one thing, beans, of course, pinto beans, black beans, mostly pinto beans here.
Mm-hmm.
There's not really an alternative for that. So I try to get them to limit their serving size and not
Mm-hmm.
so often. I mean, I have to have my beans once in a while. I really do. I just
Mm-hmm.
love them.
Yeah, me too.
As
I
well
like
as
pinto beans a
the
lot,
only thing
actually.
I do have a problem with, like getting people like the sopapillas or like trying to figure out how to make those fried breads different. That's kind of been a
Mm-hmm.
challenge. But for the most part, I have a community and where I actually have my family practice, where I do family practice is actually on the outskirts of Albuquerque and Los Lunas, New Mexico, which is more of a rural little village. It's amazing what my patients have done. They have come up with recipes that are low carb empanaditas, how to incorporate our culture, and which this year, 2020, where they had given me permission to have like an afternoon class with all my low carb community to share recipes and what they've learned, how to switch our different amazing foods that we have here and still keep our culture, but in a healthier lifestyle, and how we can pass that on. So that's that ripple effect of everybody just trying to help their community. I hope, once we open back up and everything goes well, that we can start sharing those recipes. And if these recipes are something that we can share to diet doctor and pass
Right.
it on and pass it on. And that's the goal. But I mean, I make my taco shells now out of cheese. They're just cheese taco shells, which are the simplest. I had tacos last night, Taco Tuesday.
Mm-hmm.
Need the tacos. So I make that out of cheese, just a cheese shell, which is amazing. And it is possible. I make taco pasta. I make everything that we try to make, except for the potatoes and the beans, we try to limit. We rarely have potatoes and we rarely eat beans anymore. So when that was a weekly meal or almost every day. So yeah, it's really interesting of trying to come up with different recipes, like you said, but there is a large majority of people really working on that. And then only
Mm-hmm.
indulging in those ones that we love during special, like Christmas time, like tamales.
Mm-hmm.
We always make
That's right.
tamales for Christmas time
That's
or,
right.
for Thanksgiving, and indulging in those times, but not every day and every week.
That's right.
It's doing harm. It really is.
And I do think that we should, again, we have some processed food addiction folk out there that may struggle, but for a lot of us, we can enjoy our holidays and eat those foods then. You just have to know who you are. But I really, I think it's just important. The culture is so important. We just have to honor the culture and do it in a way that respects our body as well. And it's okay to learn. We're continuous learners, and we're just hoping to spread the message that by being a continuous learner, you can do wonders for your body and the bodies of your family. So I also think about the challenges you may face as you have to deal with, a busy clinic. And I know for me, at my clinic, I have 15-minute appointments, which is what I do. I have the luxury of a note-taking service, so I can cheat a little bit. But then I also have clinicians who have 20-minute appointments. Either way, it's 15 or 20 minutes for a typical visit. And so I've learned to be very focused, and I also have learned to have little phrases I can click. It's almost like a copy and paste, a dot phrase I can click into a patient's summary that'll give them principles of low carb. And then I refer them to my drtonyhampton.com website. I have my link to my low carb corner, and Diet Doctor has a link at the top which has some handouts that they have on their site. A couple of videos on the webpage that'll teach the how and why of, adopting a low carb diet. So I have these little cheats that help turn that 15-minute appointment into a lot of information, and they have homework to do. My question to you is, how do you get that message across in a short office visit? I mean, do you have any things that you utilize Do you refer to different sites? How do you get that information into their heads?
That I do. I like the telemed visit, which we're having right now, because I do get my full 30 minutes with them. With in office, it usually ends up being 15, 20 minutes appointments that I get with them by the time they're roomed and everything. So I do have to, with new patients, it's a little bit harder. I don't get much. I have to really talk fast, and then understanding what I do and giving them an option. It's about giving options. Like, how do you want to focus your healthcare in your life? And they're just like, what do you mean?
Right.
And I'm like, I will do, and I give them options. This is me. Okay. I show them my thought process in regards to low carb and looking back at just even, I think the Spanish didn't arrive here and start incorporating their European to like 1540. So it's not that long ago in our generations that we were hunters and gatherers here with the Native Americans. So their DNA is more susceptible to a low carb diet and eating lots of meat.
Right.
So I talk about that. I tell them, look at the past, look at where we are now. And their eyes just kind of open and like, no one's ever told us this, and that food's making us sick.
Right.
And I give them the option of saying, okay, well, this is what you can do. These medications are only Band-Aids, right? They're only Band-Aids. They're not going to cure you. I'm not going to be able to help you can't just eat all the sugar you want and take these Band-Aids. It's not going to work. We're just going to add on more Band-Aids. And when I add on this Band-Aid, it's going to cause this problem. This Band-Aid is going to cause this problem. And you never get off of them. You just get on more meds. So I'm all for people making choice. We live in a wonderful country. You can make choices. Which way do you want to go? Do you want to continue being sick and taking lots of medication, or do you want to give this a try? Just give me 3 months.
Yeah.
And when they listen and they are like, okay, I have a choice in my healthcare. You're not going to just tell me you need to take this, you need to diet and exercise and send you out the door. And I'm like, no, absolutely not. Like, I am here with you. That's what primary care is. That's where you see your care in the future. They really, really appreciate that. And then they have the opportunity to step back and say, yes, I want to give that a time. And by that time, and I've rambled on so quickly as fast as I can, I then go to dietdoctor.com. I do use the handouts and the brochures, which I love. And I thank them so much for having those. They even have them in Spanish, which makes it a lot easier.
I know.
I have that all ready for the patients. So I have little packets that I make for them. I show them the website, show them how to go through it and what they're looking for if they do want to start it. I always make them follow-up appointments in a month or two, depending on what they want to do, especially for getting patients on medication. Like, I like to keep close tabs on them. So they come back. They either don't come back and because they didn't go get labs and they haven't been doing good, or they come back in a couple months. But the majority of my patients, I'm so proud of. They've done so amazing. And they've not only done amazing at accepting it and giving it a try and succeeding, they continue to come back and get reassurance, even if they fall off, which we all do. They have spread it throughout the community.
That's
and
amazing.
It's a ripple effect here. It always has been a ripple effect, especially with our culture, Hispanic. I mean, it's always a ripple effect. We all either we try to pull each other in to help one another. So that's what I'm quite amazed just that people are actually stopping and giving it a chance and not wanting to continue on with the old way. So that's kind of where I try to help them understand, trying to give them a brief background, what we're trying to do, and give them that option. It's that simple. Like, you just give them the facts and give them the options and let them make the decision. If they want to continue to eat that way, I tell them, like, I'm not going to prevent the things that can come. So like I said, I appreciate all of you in the community and Doctor, LowCarbUSA.org. Just all these websites that have helped me to give patients what they need. I mean, I even have a handout of what they can eat at, the fast food restaurants to give them an idea. It's not something that you have to just necessarily make food at home or meal prep. you can eat out. You just need to know what to choose. The biggest with the rural areas and my truckers, that's the hardest thing with them stopping. But trying to say, okay, well, let's think about this. You have to stop at a rural area and you don't have a gas station that has just, pure junk in it. I said, well, why don't you just get a couple hot dogs, some pork rinds, and some water or sugar-free drink? It's that simple.
Right.
And some peanuts or something, pecans. And they're like, oh, okay. So it's just taking a minute to just say, okay, well, what's the holdup and what are you having your boundaries in? And that's why they like coming back. I do have a very full schedule. So it's because I like to keep track of patients and make sure until they're ready to go off on their own and they don't need me so often. So that makes it amazing. And I think that's where our education process plus knowing culture and the foods that might be a pushback and how can we get past that? Like you said, with like the cheese and the pastas and cornbread. And so.
Yeah, I love all of this. And you remind me of why I partnered with Diet Doctor. There's no need to reinvent the wheel. Like
Right.
we all have our purpose. And like you, I refer people to the Diet Doctor. And then you mentioned Low Carb USA with Doug Reynolds and his wife and the work they're doing. And then it all of a sudden creates this society of metabolic health practitioners. In fact, I'll probably ask Doug to come to the podcast and talk about that because we really need to join the expertise, but more importantly, let's create some standards. Adele Height, who I interviewed in a previous podcast, helped to write some guidance. So us metabolic health practitioners, what should that look like? And that way we already know you don't just follow guidelines just blindly because that got us into trouble. But at the same time, it's nice to have some guidance about if you're going to do metabolic health, low carb, keto, carnivore, what's some guidance so that those younger clinicians who are new and the more seasoned clinicians who are not familiar with it, they'll have a sense of how to do it. So I do appreciate what you're doing, which is similar to me. Let's take those resources already in place, use them, and then partner with them because maybe I can provide some insight from an African American perspective. Maybe you can provide some insight from the Latin American and indigenous perspective, and it's just a no brainer. And so why reinvent who you are when you already have that information? So I think that's wonderful, and
absolutely. And ultimately, I do probably have to give more of a shout out to Ken Berry because he was that was the first book I read.
Oh yeah.
And his YouTube videos were what led me down the actual path of LowCarb, USA.org, and dietdoctor.com and those websites.
Yeah.
But I also use him for patients to view his wonderful videos because they're so at a level of education that he can reach everybody. It's not way above somebody's head. It's not too slow. He has his education marks and he's really taught me how to teach as well. So I do have to give props to him.
Yeah. Shout out to Dr. Kim Berry. And I agree 100%. He just keeps it real, blue collar, just, keep it simple. And that's what you need. And that's what resonates with people. So definitely shout out to him. And I know that as we started the conversation, I mentioned, how so many of the indigenous American babies were, forcibly adopted or sent to boarding schools. And I'm sure this has had a psychological impact on them and the generations to follow. So have you seen in your practice, because would you be in family practice, some of the psychological impacts of that previous history?
I can only say what I understand with my grandfather. I don't live on the reservation or on tribal land, and I didn't get to see a lot of that culture that is from my family history. But what I've seen with my grandfather and the things he's told us, that they would not let them speak Spanish or native tongue. They had to learn English. And I've seen it ripple down to where I should know Spanish and I should be bilingual in this sense and pass down that. I see that part of it. he had to drop out of school to help raise his family when he was 15, 16 years old, which really put hardship on him. And it was always hard for him, very hard. He always harped on us to go to college, and I was the first grandchild to go to college and get my degree. My sister has, and so on and so forth. So because he didn't get the opportunity, so I see that part of it, and I assume a lot of that is passed on, and them having to drop out of school a lot of times to help support the family. It also possibly we have a huge problem with alcohol within Native and Hispanics. And where did that all start? Where did it possibly come from? Is, why is there such a prevalence of addiction with that? And it could all lead back to that. Honestly, I'm a psychologist. I'm not quite sure, but it has really impacted I think, in a sense of them having to, I see on the reservation, and a lot of my patients I've taken care of and try to get they had open heart surgery and they need to go home now and they live on the reservation, but they don't have running water. So we can't safely let them go home. And this is prevalent throughout the rural areas. Not, some farms still don't really have running water. They have outhouses like the Old West. They have a well. So that makes it challenging as well. But as they're very poor, what's cheap? Potatoes, beans, flour.
Right. Yeah, good point.
Some of these places only have they have to drive an hour or 30 minutes just to go to actual grocery store and only have a gas station there.
An hour and 30 minutes to go to the grocery store.
Albuquerque is the biggest city in New Mexico, and we're still small. We're not even 1 million. We're like 600, maybe 600,000 individuals in the Albuquerque metro area. Otherwise, the majority of the towns, Santa Fe being the second, and Las Cruces, it's very rural. I have patients that are 2.5 hours away. How am I going to, they have to drive that far just to see me from way down south. So again, I think there's a large, because of our community and the obesity and the not being able to get real food in some areas. And Walmart is the majority of stores in the smaller towns too.
Yeah.
So, and that's not always you have to really pay attention to what you're getting there for good food. So that's hard and has prevalently caused a lot of, I'm sure, obesity in our community, and just having to pass on those traditions of living on an income, a very tight income. So it's hard. It really is hard to try and get people to change those ways or try to figure out cheaper alternatives. So
yeah, I see a ton of, speaking of Walmart, that's a great place to go to, kind of get a sense of the landscape where you live. And when I go into the Walmarts, and particularly when I visit, there's some genes and families, just family members in the South. Man, you go into a Walmart and you see a lot of people who suffer from obesity and diabetes, you assume. But so when it comes to obesity, it sounds like the prevalence of that in that community is pretty high. Is that kind of what you're saying? You see a lot of people. Yeah.
Yes, it really is. And even in the younger children, because we're seeing the obesity rise in children. But it is very much prevalent through our, the Native and Hispanic culture. But it's almost every culture anymore.
I think it's getting to that point.
It's not so much that it's because of one or the other. It's just the junk's so cheap. The Prime Minister in Mexico was blaming everyone being so sick because of Coca-Cola. Well, it's cheaper than water.
That's amazing when you think about it.
It's cheaper than water.
Haven't heard that before, but it's. I'm gonna have to do a price check, because I do see people when I'm in the grocery stores, particularly at Walmart, because I shop at Walmart and I shop at Aldi. And when I'm in when I'm in line at Walmart in particular, I see a lot of people with cases of soda. I never took the time to see the cost, but
Mm-hmm.
uh, that's crazy if it's cheaper than water.
Yeah,
I
I
mean,
mean,
that's,
that's what he was blaming it on because in the rural areas,
oh my
the
God.
the bottled Coke, all those stuff was cheaper, and it really, I mean, even if you, I've looked at prices, and a lot of times, yeah, it really is cheaper than water compared to.
I don't know. I'm laughing, but I'm crying at the same time. It's like, how could that be? It's like, oh my God. Oh my goodness. So I assume that because of the prevalence of drinking soda, you know, when you're doing labs, you probably find
Oh,
diabetes, like, or borderline diabetes for sure. But I see diabetes and borderline diabetes so often that, I mean, it's, you know what's good though? I will say this. When you become known for low carb like you and I, right?
hmm.
I don't see, like I used to see these, you know, eight hemoglobin A1Cs of 9, 10, 11. I do see it when I start seeing people. And then I have a few outliers who haven't fully engaged. But I generally see 5, 6, and 7s now. Like, and I honestly, I thought about this a few weeks ago and I was like, man, all these patients I see, so many of which have been treated for obesity, diabetes, and I don't see those 9, 10s, and 11s and 12 A1Cs anymore. So people are really listening. And if for anybody listening who doesn't believe it's possible, it is so possible. And it's so real. And I recently had a patient come see me who I literally was getting a shot for COVID. And I met somebody and ended up being my patient, but there were tears that fell. And I think the reason why tears fell when we interacted is because she had heard stories of success. And she knew that she was talking to the doctor who is known for helping people in that way. And what we're trying to do is just give people hope that they don't have to be a pincushion for the rest of their lives. That there is another way, that you don't have to be on medicines for the rest of your life. You don't have to be on insulin for the rest of your life. And the beautiful thing about it, if we could just get people to engage, they can turn that around within weeks and months. You can turn it around. I've seen people from one visit to the next get off of insulin or off their pills. So it's very doable. And I just think, I'm just so happy the universe has blessed us with more people like yourself. And I appreciate that. Do you have any particular success stories of patients who have done well that come to mind, who really were struggling and were able to turn it around?
Yeah, absolutely. I mean, you talk about 10, 11s. A lot of times I see 15s, 14s,
Mm,
to the point where they're losing weight because they've been so sugar high for so
right,
long. They're
right.
just, and I have tons of success stories with patients. I have a wonderful couple that just made me cry with the Christmas card they gave me. But
Mm-hmm,
they were coming on to being 65 and retiring, right? And I gave them the option. What do you want to do?
mm-hmm.
And they decided to take the path for me. And so in like their Christmas, they were just like so thankful that they're doing great and they've lost the weight and they're off the medication. So I've saved them $500 of their retirement that they don't have to, they can enjoy because they
I
don't
know.
have these medicines anymore.
Oh my
Now
God.
that's amazing stuff. You come off and get on Social Security, you make $1,200. You get $1,200 maybe or whatever you might get, very low,
Mm-hmm.
and having to pay $500 or more for insulin and all these statins and blood pressure and everything else that they want people to be on, and taking them off and just showing them a different way of eating, and they have that much more for retirement. I had a
Right.
I had a wonderful, this summer. His A1C truck driver couldn't drive if he's on insulin, so he had slacked and he went to like 14. This was in
Mm-hmm.
April. By June, he was 5.3 and off all medication, off insulin, by everything.
Mm.
We just got him off of it. Tons of story of people just saying they saved their lives with depression issues. They're no longer
Mm-hmm.
on depression medication and they feel amazing and happy, and I gave them their life back and they're feeling control again. Um, Weight loss stories. I mean, I have one individual that's about at his 100 pounds since last year. Great. I mean, he's done
Man.
amazing. He continues to push forward. And he even has tried to start his own little community and trying to help
Mm-hmm.
others as well. So that makes me proud.
Mm.
So just time and time again, I can tell even if their labs aren't that bad. Like I started checking insulins now because I tried to
Yeah.
give them and with insulin resistance, trying to give them an idea of when the possibility that they're going to start turning
Hmm.
pre-diabetic, and I'm talking about insulin resistance and insulin sensitivity, and so I do check a lot of insulins a lot of times, but I can tell automatically even if their labs aren't that bad. Once they come
Hmm.
back for their follow up and check their labs, and I compare them, amazing differences. Even
It's
if
night and day.
their kidney levels aren't, the creatinine, their BUN, all these levels that we check for kidney function, and their GFR aren't necessarily in a stage 1 or so. But
Uh-huh.
now they're, on a little bit of a higher level, but they're even better the next time. So I can honestly, the second I look at a patient's labs, I can tell whether they've been doing the diet or not. I
That's
can
right.
automatically tell, even with the liver function,
That's
everything just
right.
goes down. I mean, even with me, I was stage like 2 kidney disease,
Wow.
and I'm no longer anymore. I have a
And see,
GFR of like
people
100, point.
people won't believe it.
They
I
don't.
mean, let me just say this. I just had this conversation today, and people won't believe it. And I was talking to my care manager team, and we were looking at a case, and the patient's creatinine was 2.0. And I engaged the team and that's a team of nurses.
Mhm.
I said, let's get that patient to see me. And when I talk to the patient, I'm going to tell them that you can take that creatinine at 2. Now, it's hard when it's at 4 or 5,
Right.
but if it's at 2 point something, I've seen so many patients take a creatinine, which is a measure of kidney function, down to normal. It happens almost all the time if they do the diet. And and I honestly don't recall in my career as a doctor, I've been practicing, if you start with my residency, I've been practicing for 28 years. And in my career, until I started doing this, nobody's kidney function got better. It would either stabilize for a little bit or it would continue to get worse. It never went backwards. Never. And and this is the thing that's shocking. You have a conversation with my colleagues in the nephrology world, and you share a success story. And there's this sense of that's interesting. It's almost like they think it's an outlier. And that's why I think the work of the docs like Dr. Tro, who was a guest, when
Mhm.
you got to do research, right? You got to just share with the world. This is not an outlier. This is what
Mhm. Yeah,
happens when
exactly.
you get all this inflammation. When you become metabolically healthy, this is what happens. And so there's no need to be afraid of dialysis. There's no need to figure out if somebody's going to donate a kidney. There's no need for that. The key is to get that done sooner than later so that you won't find yourself already at that point. So now let me ask you this. Your experience has impacted people in the community, but how has it impacted you? I mean, when you first started your practice, had you already gone into the low carb space, or did you practice a little bit without that? Because when I started my practice, I didn't have all of this great information, so nobody was healing. What about for you? Because I know when I started doing this, my life changed. My whole perception of who I was as a doctor changed. What about
Absolutely.
you?
Absolutely. How can I continue to knowing the common sense, and it's pure, it's common sense when you start looking at the diet and our history and our genetics. Let's see, like I know not only just it affects me with my own health, right, but that sense of being able to actually help somebody, and
Hmm.
not just give them a pill and they just come back getting with more symptoms, like I'm tired, I'm fatigued, I'm losing hair, I'm, all
Hmm.
these other symptoms that go along with it. But it really shined a light with that. It really has. I mean, it pushes me forward to say I can't continue to lie to people and say that this is going to help them.
Right.
I can't in my practice, like knowing what you know now, and what you
Hmm.
continue to educate yourself, which us in this world, we continue to educate ourselves. We continue to
Hmm.
read books now and look at pushing the boundaries of what's right or wrong. How can they say that that's right anymore when it doesn't help?
Hmm.
So that's kind of where, yeah, I mean, that's where I started to notice. I did do keto prior to starting my practice. I started it and like I said, I just started getting better. And then in the beginning, I was, just trying to feel the ground. Like, then I was like, I can't do this anymore. I just can't tell these patients or just give the guidelines of, oh, you have diabetes now. Here's 3 pills.
Right.
Diet and exercise. So I started saying, I have to tell them, I have to give them an option, and I have to be that support. And not just tell them here, but actually be a support, because, and ultimately isn't that primary care? Is continuing to help patients to live their best life in the way that they deem their health should go. So yeah, that's how I've just kind of continually tried to educate myself. If they have questions, I always try to go find out the answer.
I love it.
If they can't find it, because a lot of my patients are always looking for research and don't just take my word for it. I never tell them, don't always take my word for it. You can do your own research as well.
That's right.
And there are great websites or reputable, journal journals that you can read.
Yeah.
And they appreciate that. I definitely see that.
Yeah, so you started earlier by saying that you try to align the goals that they have with what you're trying to achieve, and then you also sounds like you're coaching them. And what's funny about all of this is we're trained to diagnose and treat, and of course, if we do a good job, they give us a badge of honor. But man, being a good clinician is about coaching and inspiring and aligning goals and working on goals together, not the doctor's goal or the nurse practitioner's goal, but the goal of the patient. And I think that that's very powerful, and it really does increase the yield of success. It just really helps. So I really completely get that. And I am curious a little bit about you mentioned a little bit about people, they live far away, rural. It sounds like there's a lot of financial struggles. So what have you been able to do to deal with that? I mean, do you have a structure with your clinic are they getting Medicaid? How are you guys paying the bills or allowing them to get access if everybody's struggling? A lot of people are struggling. So how do you guys work around that?
Telemed's made a world of difference for the rural area. The bad thing is not, trying to get them in eventually for an actual physical. But reaching those patients I have many, many patients that have not been able to get into a primary for months or move here and didn't realize how it's so hard to find a primary. And it takes months, and they're months without medication. I had an individual that had been 3 months without diabetes, hypertension, medication, because they couldn't, getting insurance, getting a provider, and trying to get their medication. I think that our corporation has really made a difference of trying with the telemedication to try and reach these people. And then it gives me a little more time, to start talking to them and trying to figure out boundaries, like you said, with what they have in their area for of going to the market for food. And whether it's trying to, when they do go to buy food, to try and, it's not so hard if they can just say, hey, like Diet Doctor, I love the meal planning thing. It's like, pick your protein, pick 1 or 2 above ground vegetables, and pick your healthy fat.
Yeah, keep it simple.
Keep it simple. It's that simple. You don't need all those fillers. Why? You don't need to eat that much. And
you won't be hungry. You won't be hungry. That's the funny part.
That's the interesting part. The majority of the time, and my patients begin fasting before I even introduce fasting, because I usually get them to try to adapt low carb first.
Yeah.
Adapt before you start introducing.
That's right.
Fasting. Now at the point where you just kind of start naturally fasting a lot of them because they're not hungry. They're not hungry till the afternoon. And some of them are like, is it okay? Everyone's getting mad because they call him Hita, or the grandma's Hita. You need to eat.
Right.
You need to eat. Here's some potatoes. You're getting too skinny. So that's kind of, and they're like, I'm just not. And so like they're making them feel bad. And then I have to tell my patients, no, it's okay. It's healthier to actually fast and only eat
Right.
when you're hungry. And that
Right.
helps maintain your weight, and only your body can also, eventually, like when people start looking at autophagy and everything, starts healing. So that reassurance again, that coaching, that coming back, and
hmm
their families telling them, oh, you need to eat more. You really,
Right.
and that's what I heard the other day. It was like my grandma was harping on me. She was, hita. And so I was just, that's just kind of a sense of the culture and how they worry
Yeah.
if people aren't eating. And love, and that's another thing with the culture here. They use food it's love.
hmm
It's a love thing. Like, I'm feeding you, grandma's feeding us, mom's feeding us, and it's love. It,
Right.
that's why they feel like, oh my gosh, you got to eat. Let me go make you something. Let me go make you. Let me go make you some. Let me whip up some tortillas really quick and make you something. How do we break that cycle
Yeah.
when it's
Well,
a feeling of love for them?
right. Well, I guess, as that knowledge increases, the love it will still be feeding them, just be feeding them a little different. And I think we just got to get more and more people learning the right, I hate to say right, but the metabolically healthy way of doing it. And I think that'll get us there. And it's funny hearing you talk, because it feels like a lot of our cultures are the same. And
Yes.
I know that a whole lot of cultures want our babies to be chunky and fat, and we want, we want to feed people. And even when I was in college, my first roommate, he was Creole, and we would go to his mom's place anytime. It didn't matter what day,
That's food.
didn't matter what time. Baby, I need to feed you. And it was like, and they looked at me like I was like anorexic or something. They thought I was sick. So their expectation was you're going to eat, and saying no is like almost impossible. So
Mm-hmm. It
that
is.
resonates with me big time. So
Yeah,
one of the
especially because we were learned to respect our elders.
Yeah, well, that's it. And it's hard to turn away their, blood, sweat, and tears preparing a meal and not feel like you're disrespecting them. So I am there, and so that's funny how true that is for so many cultures. And one of the things as we kind of wrap up, I wanted to ask you about the name issue. When I did a little research in preparation for our conversation, I heard very many people who was from the indigenous community, which is why I've used that term. I
Mm-hmm.
just felt like it sounded like the term that would be the most respectful, but I know a lot of people say Indian American, and I was curious, since you're in that community, what exactly, I know it probably varies from person to person, but how do people want to be referred? Um,
I
what's
mean,
your thoughts?
in our
Is
area,
it tribal? Is it
we have
tribal?
our native. I mean, and I always say Native American because that's a lot of our areas of like our even our websites in Albuquerque
hmm
and stuff. It talks Native Americans.
hmm
So we use that term as politically correct, indigenous people
hmm
as well. But I can't speak, like I said, I mean, both are probably more efficient. Some may like one or the other. We
hmm
have 23
Sure.
tribes here. Like, we have 23 tribes
23. Ouch. So that's a lot to.
of different,
So even if you
from that.
tried to be specific to the tribe, that would be difficult.
Yeah, I mean, each one has, a lot of them have similarities, but they all speak in their sense, their own tongue, and it's pretty
hmm
neat. It's really an amazing
Right.
community. I mean, we have the biggest, the powwow here in New Mexico, where they come from all over the country to celebrate,
hmm
which is a really big event here a lot of times. But um, well, every year except for this last year. So I can't, like I said, I can't say whether which one is technically politically.
hmm
I just know that
Right.
a lot of time here, we majority of things are native culture.
So native and indigenous are probably the safest ways to
Yeah,
go.
yeah,
Sounds like.
and of
Okay.
course we either, it's not so much in. We use Hispanic culture here, like the Hispanic culture, Latin American culture. I mean, it's so huge, that culture, because
Mm-hmm.
Mexico is so, between Mexico and Spanish, we're all mixed. And
Mm-hmm.
so that's kind of where the majority of people, it's a Hispanic culture, or I rarely hear Latin American culture here, but it's
Interesting. What about Latinx? I've heard that in
the
the
what?
media. Latinx, do
I
they?
haven't
Yeah,
seen any of
yeah,
those.
that's right.
I mean, I
I've been hearing it lately, and I'm like, okay, have
there's
you
so
guys
many.
talked to the community yet?
Even our Spanish is different from other. It's similar but different.
Okay.
So even the language here, the Spanish, is different from Mexico and um, southern, where they speak proper Spanish, I would assume,
Hmm.
and Spaniard, Spain.
Right,
So
right.
it is different. It really is. So it's a very it's a great place, I think, for providers to learn that, to learn the
Hmm.
culture, to learn how. And there is some very, very sick individuals here. I mean, they're extremely sick. I mean, the amount of diabetes in this area it's
It's like a
it's
pandemic.
I mean, because of the culture and the food and everything. But
Hmm.
you
Yeah.
talk about some sick patients, and I've heard from many surgeons and doctors that have worked everywhere, and they've said by far through the country they've never seen so many very sick individuals in the
Hmm.
state. So we need providers to help, and we need
Yeah.
people to start really trying to adapt to this diet, and stop looking at the guidelines that are set forth that have not helped in the last
Right.
20, 30 years.
No,
It's
they have
not.
not helped. Yeah,
We're just
they.
getting, our obesity rate just continues to go up, the diabetes, everything. So
Well, that's because the guy. I mean, Nina Teicholz, when she was on the podcast, she talked about the dietary guidelines. I've written an op-ed in Chicago Tribune about the guidelines,
mhm,
and what she would say, they were written for the 12% of people who are metabolically healthy. And you could argue not even for them, but
absolutely
the 88% who are not metabolically healthy, which is the rest of America, should not follow the dietary guidelines. It's just because they didn't do anything with the guidelines. They completely excluded any research based on what helps diabetics, what helps hypertensive.
right.
So what's the point? So it's almost like you can't believe it. So if anybody who wants to hear Nina Teicholz talk about that, check out the
Amazing.
episode
She's
with her.
amazing. Yeah.
So wow.
Yes.
So I want you to be healthy so you'll be able to continue sharing your message. And I always wrap up with my question about my acronym, my nest and rope. And again, as a reminder for those listening, nutrition, exercise, less stress, more sleep, thinking positively, avoiding trauma, and of course, being in supportive relationships, avoiding harmful organisms and pollutants, and of course, protecting your emotions and only holding on to life experiences that support and serve us. So when you think about your 2021, where do you think you'll give the most attention?
For myself or for other individuals?
For Jamie, I
Ah,
want it to be for you. I want you to be healthy because you can't do this great work.
absolutely.
Yeah.
It has been a huge, since this last, since COVID. Like, I was doing so well on my path to where I ultimately want to be, and working out and having a routine that I loved, and it has put a damper in all of this. So this year I really have looked at not letting these things stop me, and the
Mhm.
ups and downs, and the downs just dragging us down, and pushing forward, because we all have in our lives, but to continue to push forward and get
Mhm.
to those goals. And that's kind of in my health, and looking at, like you said, continually fighting and eating what we need to eat.
Mhm.
Um, Began to exercise and create what I could in our own home.
Yeah, that's been my secret, by the way. I just to segue just a little bit.
Yeah.
I normally exercise every other day, and there are some days when I get into the bathroom and I didn't exercise today, and I'll just do it in the bathroom. And
Mhm.
I'm just talking about push-up, squats, nothing major. I'll put something in my ears like a podcast, and I'll just spend about 20 to 30 minutes doing that. and I'll do 4 sets of each, and I'm good.
Yeah,
So
that's all you
I
need.
just do, yeah. So this is not rocket science. And if you can't do squats because you got bad knees, there's other things, So I do appreciate you, really wanting to get that exercise in, because although it's not the number one way, it's not the way to lose weight, it's to maintain weight loss.
Yeah.
But you're just so much healthier when you exercise.
You decrease your stress and cortisol levels.
Yes.
Cortisol. I mean, you ultimately do. I mean, and that will help you sleep better. And that's another goal, is just trying to make sure I get more sleep.
Yeah. Yeah. Just being on a schedule and just honoring that schedule. And then on the weekends, maybe not having an alarm,
Right. Exactly.
things like that when you don't work on a weekend. So I love it. So any final takeaways, and how can the listeners find you? Do you have any presence anywhere where people can find you?
I do have an Instagram where I do, that I'm on there as a family practice provider for keto carnivore type thing, which
Mm-hmm.
is just JME Sandoval. I don't really have any other platforms. Most people do actually find me off Diet Doctor and start calling to try and make appointments and try and get in, especially if they have the insurance
Mm-hmm.
too, which is always a good thing. I'm not techy enough to have my own website or anything. So, I mean, those are pretty much, that's all I really have. I'm not huge in the sense of, as you guys with your social media and everything. I would like to work on that as well, but especially for the community. But like they can always look me up on the internet. I mean, I'm searchable to see where they can call and
Absolutely.
possibly try and get in or try to help them, and hopefully eventually maybe they'll pilot a clinic here. That would be amazing.
Yeah.
So that
Yeah.
right now, that's about it. But if
And
anyone,
that's good. I mean, I before I got very active, I kind of, you kind of appear out of nowhere. So I
Mhm,
think you have to decide if that's going to add value for the population you're serving, or if you're trying to spread your message beyond those borders. But I think what we're trying to do today is to, just provide another perspective, and I think
exactly.
you were able to do that. So
That's all I wanted, was to provide another perspective of how I am trying to take a step back and say, okay, what do we need to do to teach individuals, but incorporate that there might be some pushback because of certain culture, foods, and family.
that's right. And I think we achieved that. So thank you so much
Thank you.
for being with me. And I'm looking forward to getting this out right away and hopefully share it with the world. And so I'll just close by saying, I'm so grateful. We've been able to share your insights and just a different perspective. And I'm just happy that your work is making a difference. And for those listening, today we took a mental trip to New Mexico. I like to travel. So since we can't travel with COVID, we have to do ours mentally, virtually. And our tour guide is an inspiring nurse practitioner committed to improving the health of the community she serves. And, we learned a little bit about the native. Now I know native and the indigenous folk in the community she serves, and instead of saying Latin American, I think you said we should say, what's the term you said? What was better?
Hispanic.
Yeah, so we'll just say Hispanic, which is I thought was older, but that's here you
Yeah,
go.
we
So I'm
still,
learning every day. So
yeah,
thank you for that. So we learned a little bit about those terms and how to be respectful. And I am thankful that we now have somebody in New Mexico teaching that food is medicine. And we want to make sure that message is shared throughout the world. So now we understand that community better, and we also know that there may be ways for us to maintain our traditional foods by having alternatives with a low carb twist. So that's
yes.
very reassuring, which is cool.
Hmm.
I'm hoping one day to visit a reservation. And let me ask you this last question. A
Hmm.
good way to support I'm assuming just by visiting and doing those. Is that a good way to support the ideal of a reservation and provide? I mean, what's the best way to do that?
I'm sure we have a lot of places here with the Indian health reservation. Like they're always needing help and money, and
Mm-hmm.
they're
Yeah.
limited on their resources,
Mm-hmm.
of things. So there is an Indian health centers that we have throughout
Mm-hmm.
that are always looking for help of needing things, and
Okay.
water. I know they're trying to get running water everywhere and work on that. But there's many
Right. That's
websites that you can
just
look out
thinking
there. But
about
we do
that.
have a lot of places that you can look in New Mexico and helping our community here that is in
Okay.
need, really in need.
Well, thank you. I just wanted to get that out. I just want to make sure everybody listening who has that in their heart and they want to let that community know that they care, there's a way to do it. So thank you for that. I really hope this episode has given everybody listening some food for thought, and it helps to continue to shape all of us in ways of caring for our neighbors. So as we wrap up this episode, I will ask that you continue to be safe, to be well, and to continue to protect your nest.
You as well.
Thank you. You've been listening to Protecting Your Nest with Dr. Tony Hampton. For more, visit drtonyhampton.com.